Today I have with me Dr. Paula Bistak, who is what we in TOK would call an expert knower in the field of ethics as it relates to scientific research done on humans. So the first thing I'm going to have Dr. Bistak do for us is give us a little bit of background in terms of her education and work experience to let us know what makes her an expert knower in this field.
Hello. I started my career as a registered nurse, went on for a master's degree in health administration, and then furthered my education by getting a doctorate in medical humanities. And you might be wondering, well, what is medical humanities? It is kind of the human side of medicine. Medicine is more, the clinical physiology of what's happening in a body. The medical humanist looks at how does that affect your life. So now, in other words, diabetes might affect your pancreas, and that's what your clinician's looking at. We look at how does that impact of taking your blood every day and taking medicines every day impact how you feel about yourself and how you actually have to implement that. So that's my educational background. As the executive director of the Human Subject Protection Program at Rutgers University, that's where I had really firsthand experience at reviewing research that's done on human subjects. What the Human Subject Protection Program at Rutgers consists of is, first of all, our review committee. All human subject research that's done at a institution is reviewed by an expert committee called the Institutional Review Board.
So tell us a bit more about this expert committee and what they do for human subject protection.
Right, okay. The expert committee in the U.S. is called an Institutional Review Board. In the U.K. and in some other countries, and I even believe in Canada, it's called the Ethics Committee, Research Ethics Committee, so EC or REC. Well, this committee is made up of scientists, various scientists. You may have doctors, nurses, you have social scientists, you have the physical scientists, you also have committee members who are from the community. So they don't represent the institutional interests, and you also have specifically non-scientists. So usually we have about 15 individuals, and they also have alternates, but 15 individuals, so you get a broad spectrum of people who are reviewing research. And also, as I said, the community and the non-scientists are very important because you want people who are really representing this human subject that might be in these research studies.
So these ethics committees and institutional review boards are a fairly modern introduction into human scientific research. Can you tell us a little bit about how people realized that this was something that we needed in order to conduct ethical research on humans?
Okay. Well, very briefly, institutional review boards really came out in the 1970s. And at that time, maybe you're familiar with what is referred to as the Tuskegee syphilis study, where African American males were put at risk, and the media became aware of this, and society became aware of some of these instances where individuals were taken advantage of. But the idea that we needed ethics really goes back to World War II and the Nazi experimentation on prisoners. And the Nuremberg Code was one of the first historical documents that spoke about the ethics of human research. But there had been a number of other instances where individuals, again, had been taken advantage of, vulnerable populations, and then in the 1970s, in the United States, the president forms a commission, and this commission then, part of it is the formation of institutional review boards.
So from this commission was the creation of the Belmont Report, which was a foundational document in the implementation of these institutional review boards. What was the Belmont Report?
Right. The Belmont Report is sort of that treatise that sets what are the ethical principles that undergird human subject research. And there are three principles that are cited. The first one is respect for persons. The third, beneficence, which is do good. And the third is justice, so the fairness of research. So from these principles, the regulations that we have, the federal regulations that we have for human subject research are undergirded by these principles. And so then the regulations are the way we can apply the principles. And for respect for persons, the main way we apply it is from consent. For beneficence, doing good, these committees will review studies for their risk-benefit analysis. In other words, is the benefit of the study worth the risk that you might be exposing someone to? And third would be justice. And justice is really exploding right now currently. And that is, who do we enroll? Are we targeting certain populations because they're vulnerable, because we can kind of use them? So respect, beneficence, and justice.
Knowing all of this, how does the IRB decide if a proposed scientific study is ethical or not?
Actually, that's a good question. Most people think, all right, it's not totally our opinion. I might think something's ethical versus you might think it's not ethical. Well, the IRBs base their decisions on regulations, and the regulations have very specific criteria on how we judge each individual research study. For example, I mentioned respect for persons, and one of the ways it's applied is through the consent and the consent process. So those boards look at the consent document. We see if the specific criteria that's noted in the regs is included there about providing the information, the understandability, and the voluntariness of the study. Or we'll look at beneficence, and we'll see this risk-benefit analysis, and we actually conduct that, and there are certain questions that the IRB goes through to see, all right, the risk of a study could be very great if you're a cancer patient with no other options. So we might allow a higher risk because of the potential for benefit. But if there's no benefit, then we're going to say, well, it's too risky when there's no potential benefit there. And the third one, as I mentioned, was justice. So we're going to look at who's enrolled. Is there possibility for coercion or undue influence? For example, if you're including employees or you're including a population that might have limited education. So we're going to look for those protections and make sure that they're included in the studies. So it's very specific. It's not just a gut feeling of yes or no. However, you have that institutional review board that has certain criteria based on federal regs, but you might have additional requirements that the state that we're in might impose, and also an institution itself might have a different mission. For example, a Catholic university might have limitations on what they will accept. So you have the federal as sort of the floor, then you have the state, then you have the institution, and even above that you have some departmental considerations you have to think of. Whether it's a professional like residents in a medical school, or whether you have doctoral students or undergrads or graduates, there are different things we look at to make sure subjects are protected.
Institutional review boards are concerned with research. So what counts as research to the institutional review board?
Well, this is where definitions are extremely important, because you can imagine in a world of research, there's just anything. Well, human subject research is clearly defined by the federal regulations. First of all, is this research? The definition of research is a systematic investigation that contributes to generalizable knowledge. Okay, so it's got to be systematic, and it's going to be more globally learned, not something you might just do in your classroom. Secondly, who is a human subject? And by these federal regulations, it would have to be a living individual. So we don't review research on decedents, people who have died. There are other rules like HIPAA laws that still cover information about decedents, but not the IRB. So we're looking at a living individual about whom you learn some identifiable information, or you create identifiable information. And by create, I mean when you get a specimen from somebody, can I do a genomic study that will tell me who that is? So if you're either getting it through a survey, and I know who this is, or I can create from whatever sample you give me identifiable information about an individual, that's a human subject. So that's what we look at. We look at, is it research? And we look at, is it a human subject? And that's what we look at.
You mentioned generalizable knowledge, which in TOK we'd probably refer to as shared knowledge as opposed to personal knowledge. Can you just explain that a little bit more within the realm of research and institutional review boards?
Right. Well, the expectation is that your scientific research is going to result in something that will expand a body of knowledge to everyone. All right. So when the Institutional Review Board looks at this, we say, is this a good study? So how do you judge that in general, and not even from an ethics perspective? Because if it's not good research to begin with, you say, well, it's not ethical because it's not going anywhere. It's not going to be generalizable. And to be generalizable, you look at the rigor, the reproducibility, and the transparency part of a study. Rigor would be, is this following a systematic investigation? Is this following the scientific method in some way? And scientific method varies according to your discipline. I mean, a sociologist is going to be very different than some medical clinician might have. So you're going to look at it, are they following the scientific method there? Reproducibility, would if I run my study the certain way, and so you have to be careful with your data that someone else is going to be able to do the same thing and get the same results, and that's very important as you're progressing along the way to certain medications. That this is if I do this study and you do this study, we're going to get pretty much the same results. And the third, I mentioned transparency. So what's transparency? That's where even if we get results we didn't expect or negative results, we want to hear the good and the bad. So when you report your data, we should know both sides. So that's where it's very important to be considered good research. You're going to have rigor, reproducibility, and transparency.
Now that we have this background knowledge, could you tell us what are some of the more challenging studies in terms of ethics?
What may be surprising is sometimes the most scientifically complicated, like maybe a medical device you would think would be troublesome, but the ones that are more challenging, it's really the population and how vulnerable they are that present the most challenge. For example, doing research in the emergency room is really difficult because people come in and they're in a heightened emotional state and they're concerned, obviously, and they'll say yes to anything. And we don't want them to do that. We want them to be knowledgeable and consent and have the information and make a judgment decision for themselves. And that's very hard to do in the emergency room. So we, not that you can't do the research, but we try to make sure there are protections in there for them. Other ways that some of the research can be challenging, if we're doing international research, not only international, if you're involved in illegal activity. And illegal activity is being studied all the time, so we have to protect really the informants So, and that can be ethically challenging because you have to look at the laws and what is reportable. You have to report abuse, but at the same time, you want to find out about some abuse. So those are very challenging studies.
So what kind of illegal activities?
They look at, obviously, illegal drug use, but also things as human trafficking, something as severe as that. And abuse, abuse of seniors has been some studies we've looked at. And you have to be very, very careful that you're not antagonizing an abuser by what they're researching. So those are the challenging ones. And we'll work with investigators. And just so to make you aware, a research study comes through the IRB, and it's not just a yay or nay and forget about it. It's, well, not the way you've presented it. We need to work on it, and we work on it with the investigators because they're not always knowledgeable on all these regulations and laws, etc. And often they'll come to us first to help them. But the challenging ones are your vulnerable populations or children's research. Their vulnerable population, even research with students, because if you have a professor, a superior that is doing research on his classroom or his or her classroom, you have to make sure that there are protections in place, that they will not have any ill effect from being in that research study. So those are the challenging ones.
So we're all aware of the sort of intentional bad actors within research, those who are maybe falsifying data or doing things that are they're knowingly unethical. Mm-hmm. But what are some situations where individuals or even the investigators themselves might not realize that there's an ethical issue at play?
One of the components of a human subject protection program is our audit team. And our audit team then goes out and sees what's happening while the research is being conducted. IRBs look at your study before it happens, and then we have auditors who go out and look and see what's going on. And the number one problem they find is that our investigators don't follow the protocol as it was approved by the IRB. Because in real life, your protocol might not work exactly as you thought it was. For example, maybe I'm doing some testing on someone, some clinical testing, and I say, well, gee, we don't need this, WBC, so we're going to eliminate it. But you haven't come to us and told us that, because we then have to reevaluate, does the elimination of a test make something a little riskier because you're not measuring it? Most of our investigators realize if they add something, they come to us. Another area that they sometimes very innocently don't think of it might be data security. When you have a number of people on your study team, data is getting passed around, and people well-meaningly might say, "Oh, I'll give you a true life example. If your protocol says all your data will be stored on the institutional server and institutional computers only will be used, you have to follow that." We had a circumstance where a graduate student was looking at very sensitive data involving linking TB and AIDS data, which was only supposed to be at the institution, but very well-meaningly thought, well, I could work at this at home on a weekend, right? So downloads it to their personal computer. And of course you can imagine what happens. This computer, she goes to a Starbucks, leaves her computer to go to the ladies' room, and it's gone. And poof, whoever expected this? And so there are repercussions, and you have to follow these data security rules. And there again, it was very innocent. She thought, oh, I'm going to actually be able to do more work, but you have to follow the what you said in your protocol. Because then if you said, well, I really want to work at it, XYZ, then we'll talk about encryption and what other the IRB can help you if you want to do it differently. What other mechanisms are there to allow you to take your data outside the institution? I mean, and there are some federal laws that just don't allow it. HIPAA doesn't allow data to go out of your covered entity if individuals haven't consented to it. One other area that I think might be a little interesting is that some areas of your protocol or investigators might not see some of the implications and the riskiness embedded in there. And that's why, for example, everybody says, oh, it's just a survey. I mean, that's one we get all the time. Oh, it's just a survey. I'm just asking people questions. But if I'm asking you questions, as we mentioned, about your drug use, underage drinking, I mean, and someone finds out about that, we've got to make sure protections are in place. Another one that people don't recognize are what we call secondary subjects. If I ask you questions about your mother, your brother, a friend, and if I can identify who that person is, if I know who you are, it's not too hard to find out who your mother is. And then you say, did your mother beat you when you were a kid? Or something like that. Then all of a sudden this changes. And sometimes our investigators don't realize that. One I see very often will be studies that are looking at patients and just retrospective chart reviews. They say it's just a retrospective chart review. However, they're looking at the clinical outcomes for patients. So they may also be looking at who was their caregiver, who was the clinician, who was the doctor that cared for them. Did it make a difference if Dr. ABC was their doctor? Well, guess what? You're taking information identifiable not only about the patient, but the doctor. Because all of a sudden, if you start saying Dr. ABC has bad outcomes, we have to make sure that that data is protected. So there's a lot of reasons. Go to your ethics committees, go to your IRBs, and make sure that anything you're doing is included in the protocol so they can make judgments about some of the ethical issues that arise that you may not be thinking of.
What happens if someone observes something unethical happening within a study?
Yeah, this can be a challenge, especially if you're a student and or an employee that sees their superior, who's taking a shortcut, not following the protocol. What do you do? And of course, you're concerned. Will I lose my job? Will they harm my grade? That's where you reach out to your IRB. I know you feel like, oh no, they're going to know, but we're very cognizant of the fact that this should remain anonymous. There's usually a compliance hotline at any institution that's anonymous, and you report this. And we're not going to say, oh, we got to report that XYZ is happening. Typically, we'll then send the auditors out to do a more general review of how the study's being conducted. And we do periodic audits all the time. So this is not something that, at least at Rutgers University, they did. So they would expect that every now and then they may be audited, and especially depending on the risk. So it would be something that I did want to share and say, if there's something's happening, do report it. Also, make sure if you're part of a research team, you should have a copy of that protocol and know what to be expected. Because very often the things we had talked before in another video, innocently, well, you might not, if you don't know the protocol yourself, you may just follow what someone tells you, right? Okay, someone tells me to do X, Y, Z, and that may not be what the protocol says. So know your protocol, and if something's happening that you feel uncomfortable with, of course, go to your investigator, and you might point out this is what we should be doing. And if he or she doesn't give you a satisfactory answer, share that with your compliance department or your IRBs.
What we've been talking about so far is really based on the regulations and what's done in the United States. Are there any significant differences or considerations in terms of what is viewed as ethical in other countries?
Yes, the United States is very individualistic. Okay, so our regulations are based on how they impact an individual. Now, some cultures and some populations outside the United States, even within the United States, if we look at Native Americans, the idea of consent, here we say, I have to consent the individual, but you may have to go to the chief of the tribe, and because he is seen as representing not only the individual, but the interests of everybody in the tribe. So that's something as we do more international and collaborative research among countries, and you do see that perhaps in Africa. Or in countries where a married woman or a woman might not be able to answer for herself. It's either her father or it could be her husband. So there are some things there from a consent issue. Also, what is allowable? I mean, we have, for example, a moratorium on certain types of stem cell research, especially dealing with embryos. But in some populations, in other countries, you can do embryonic stem cell research with a number of things. And one area that we have restrictions on in the U.S. is the blending of human brain cells into animals. Okay, because it's really the unknown, how that impacts the animal. If we put this in the brain, are they going to feel a certain amount of humanness? So there's, within the U.S. it doesn't happen, but it could in other countries. What we do have for certain clinical trials, that's most of your medical research, is a shared idea of what they call good clinical practice. And there is an organization called ICH, which is the International Conference on Harmonization. And that's the U.S., the U.K., Japan, Australia, some of these countries that have agreed on a certain set of standards when they're running a clinical trial that they will be following. So you do have differences between countries, even within a country, as I mentioned here, within the Native American population, because we are very diverse in the U.S., where you might have some differences.
What role does language play in terms of how a human subject is viewed?
That's interesting for me because that's basically what my dissertation was about. And it's more or less how society can construct a view of an individual by what we call them, in labeling, in other words. For example, over time, what we actually call the human subject changed. In early days of research in the United States, which was coming out of the NIH, most of that clinical research, the subject, who we now call a subject, was a patient. So you thought of that person having that paternalistic doctor-patient relationship, even though in essence they were being subjected to experimental research. Then as we progress, and that was maybe in the early pre-World War II days. After World War II, and we come out of World War II, there's this sense of patriotism, and then you'll see within the research realm, they're called volunteers. So people were volunteering. You've heard it even, the fight against cancer. So there was that sense I'm volunteering, and we're going to go against this. So it was that sense that the responsibility on me, okay, as the volunteer. Then as we progress into the 70s, when we get into the era of the IRB, you'll see more of this idea of the human subject, where they really recognize that it is the subject, the investigator, is in a sense using an individual. They're the subject. Where more currently, you'll see the term, people feel like subject is derogatory towards individuals. However, some people say, no, they are truly a subject. They don't get choices because they want to use the term participant. Because sometimes you'll hear human participant. But if you don't have a choice, we actually say, well, how can you participate? Because participation suggests there's some mutual give and take. I mean, there are research studies that individuals can make choices along the way, but most clinical trials, you have to follow the protocol. You have to do it the way they say it's being done. So just that in and of itself can change how an investigator views somebody. If I see you as a patient, I'm seeing that I can dictate to you exactly what has to be done. If I'm a volunteer, I'm saying I've got all this responsibility. Part of the idea of calling someone a participant is because the subject does have responsibility. They have responsibility to follow a certain protocol as well. I mean, now you'll see in consent forms, which wasn't always the case, where they actually say, what are your responsibilities? It's, you might have to come for your follow-up visits at certain times. You have to take medications at these certain times. And even, we're looking at clinical trials, but even if we're looking at more social behavioral, you might have a phone and they're checking to see if maybe certain reminders are going to help you exercise. They're going to help you eat right. They want you to have that phone and be following anytime you got a little reminder to mark certain things in there. So that, in a sense, is where they're trying to get that idea of being a participant and having responsibility kind of collectively with the investigator, but it's not as clear-cut as that. So that might be a couple of examples.
How much research is really being done on humans right now?
A lot more than you probably expect or suspect. Very often when I go into a class of medical students, which I'll ask them, I say, how many of you have been in research? And not too many people raise their hand. But if I start asking questions like, how many of you have ever given a blood sample, or perhaps had a tooth pulled, or a biopsy of some sort, or been in the hospital, there are a lot more. So your specimens have been used in some sort of research, because when you sign into the hospital, you usually are giving them permission to use your discarded tissue or your data, and it most likely be de-identified, especially during these COVID times. You can imagine there are a lot of researchers, besides doing these clinical trials on the drugs, they're going into medical records and they're looking at, for people who have had COVID, any sort of association or relationship with outcomes for COVID. When we talk about these comorbidities or other conditions somebody had, how does the diabetes or their weight, etc. So they're going into medical records and looking at this all the time. Then I ask students like yourself, have you ever been on TikTok or Instagram or, for some people, Facebook? If you've been on social media, there are researchers, if you're in a public website, right, and not one of these small groups, but a public website, there are researchers all the time looking at those interactions people have on these social media sites. So I always warn, be careful what you say. There are a lot of people looking in on that, doing research on it. For example, now that for an institution, for example, like Rutgers is, at any one time, they probably have about more than 5,000 open studies going on at any time. Okay, so we have right about now 5,500 studies are going on. And that's what's considered human subject studies, just human subject studies. And out of those might be about 350 that are really considered the clinical trials that most people think about. So you're thinking about those pharmaceutical trials. So you might have, or device trials, maybe 350 of those going on, when the rest are social behavioral studies, and other kind of studies, as I said, in medical records or school records with permission. There's a lot of research going on from a social behavioral side looking at people.
And that this is just one of many institutions in one state of 50 states in one country of over 100 countries. So just to give you a little bit of an idea of just the sheer amount of research that's being done. And again, these numbers are just the human subject studies that are being done, not all of the scientific research that's being done within that single institution. So the amount of research that's being done throughout the world is just huge.
Right, yeah. Oh, there is, because you've got animal research and you have what we call bench scientists, all right? That's kind of just, at your bench looking at how perhaps cells work with cells and other chemicals or such.
Plants.
Plants, absolutely.
All those things that aren't humans and animals.
Right.